Welcome to the Big C podcast series, an initiative of the Algo FM Big Walk for Cancer. I'm Carol-Ann Kelleher, and in this episode, we're taking a look at the vital role radiology plays as a diagnostic imaging tool in the fight against cancer, not only for early detection, but once the disease has been diagnosed. And with me for this essential discussion is partner and radiologist from Bay Radiology. Welcome, Dr. Sharon de Kock.
Thank you so much for having me, Carol-Ann. It's a pleasure.
It's a privilege to have you here. I know what a hectic schedule you have, Doctor.
Always.
Right, Sharon, let's start with the basics. The difference between a radiographer and a radiologist, because a lot of folk don't know what the difference is.
No, definitely not. And we get asked that question fairly often. So, very good. The radiographer is a qualified healthcare professional who takes diagnostic imaging. So they are the ones who literally works with the machines, They work with the machines to be able to produce high-quality imaging. For the radiologist, who's a qualified medical doctor, and specializes in diagnostic radiology, for us to interpret. So the radiographer is the photographer of the medical world, and we are the detectives of the medical world.
Right.
So after interpreting of your scan, then we will come up with either a diagnosis or a differential diagnosis when we exactly sure or not so sure about what it can be.
An overview of what Bay Radiology does?
Oh my goodness, and how much do we do on a daily basis, except for the imaging that people know of, like for x-rays, for ultrasounds, mammography, we do scans, we do fluoroscopy, we do MRIs, CT scans, nuclear medicine. We literally do it all. And then on top of that we do interventional stuff or procedures. And it's usually minor procedures that doesn't always need to go either to theatre, because it's going to be less invasive if we can do it in the radiology department. And that includes like biopsies. We literally do biopsies almost on a daily basis of the liver, of the kidneys, of the breast, of the lung. We do drainages, like abscess drainages or ascites drainages. So ascites is when a lot of people with end-stage cancer has fluid buildup in their tummy, and then we literally drain the fluid. Then we do more interventional kind of procedures, like we can do embolizations of arteries that is bleeding. We can do stent placements. We can do ablation of liver lesions. It's
okay,
a whole
vast.
lot more. It's very, very vast.
I didn't realize that.
Yeah.
Right. Sharon, let's talk cancer.
Yeah.
What are the cancers that one can screen for?
Yeah, we literally can screen for a lot of cancers. And the most commonly known cancer that we do screen a lot for is breast cancer, where we do mammography and annual mammography or bi-yearly mammography. We can do ultrasounds. Sometimes when people are too young to have a mammogram yet, we can do a ultrasound to look if there's something the matter. But obviously it doesn't matter of your age. We can always go further if there's something bothering us and do a mammogram on young patients even. Then we can screen with prostate, which is very prevalent in the male population these days. we will never be able to get rid of the digital rectal examination, you know.
I was going to ask you, would the prostate scan take away the need for that? Because it just strikes terror in the hearts of men. And I know the men in my family are so resistant to having it done. And it can save your life.
Yeah. You know what? The prostate MRIs that we do are mostly when something is the matter. So when you have a blood test that you can do that also gives you an indication, you know, the PSA. If the PSA is too high or there was something picked up on a digital examination, then you are referred to. You can't walk into Bay Radiology to get an MRI of the prostate.
Doctor, can we take a couple of steps back?
Yeah.
What are the symptoms that a man should look out for to kind of go, I need to have my prostate tested? Is it getting up to urinate a lot during the night? What are the symptoms? Because this is one of the cancers that early detection can save someone's life. So what should the men be looking out for?
You know what? Men should actually get their prostate checked out every year like we do with our breasts.
From what age?
A lot of young people these days, but like we also do from 40 years onward, you should actually have a yearly prostate, either examination or a blood test, and, you know, and then with follow-up examinations of the kind, you then can see what is happening with the prostate.
Okay.
All right? And except for that, obviously people, you know, there's lots of other stuff that gives you, like prostate hypertrophy, for instance, that doesn't necessarily have to be cancer.
What is that?
When the prostate becomes bigger, and we see it quite regularly, and people can get urinary symptoms with they can't empty the bladder properly, or they're dribbling, or they, you know. But that doesn't necessarily say you've got underlying cancer.
Right.
Yeah. So that is for the prostate. And then obviously for lung and bronchus cancer. So your lung is your lung parenchyma, obviously, and bronchus is the airways that lead to the lungs. So you can get cancer of that, and we see that very, very regularly as well.
So we can screen
We can
for that.
screen for that. For a lot of the times, GPs will send a patient yearly for like a chest X-ray. So we usually start at the most basic examination. And from chest X-ray, we can then work up, you know, to get, if there's something the matter, we can do a CT scan to have a better look at the lungs, for instance. And then we have like colorectal CA. That is also a very common cancer to have. Cancer of the colon or cancer of the rectum, where the rectum being the most distal part of the colon, you know, where before defecation takes place.
Is that more common in men or women?
No.
It doesn't discriminate.
No. So for screening for colorectal cancers is usually with colonoscopy, or we can do a CT colonography. And in the olden days, we used to do barium enemas, which we don't do that much anymore because there's better ways to screen these days for colon cancer. And then we get lymphomas, we get cancer of the pancreas, of the kidneys, of the liver, and for that screening we can do ultrasound. You know, ultrasound of the abdomen to see whether your solid intra-abdominal organs look okay. And a lot of people also come for like a yearly kind of screening, abdominal ultrasound, or if they have abdominal problems or complaints, you know, then we do ultrasounds.
So, Sharon, which are the ones we should all, say after the age of 40, be screening for, going, I need to go and have this done? You don't have any symptoms in particular, but this is something I need to check. So it's your mammograms, it's the prostate. Is there anything else that you can kind of screen for in terms of prevention, or is it only once there is a symptom that you get sent? by the doctor to have a scan?
A chest X-ray, like an annual chest X-ray and an annual abdominal ultrasound covers a lot.
Okay.
It really covers a lot.
Okay.
Yeah.
Can you talk us through, let's take, for example, a woman going for a mammogram. So I go for my annual mammograms. My mother had a very rare form of breast cancer. It was called, I don't know if I'm pronouncing it properly, Paget's?
Yes. Yeah, Paget's.
So I go for my annual mammograms and my sister as well. Unfortunately, you have everything done, you get told to go and sit and wait, and then you sit and wait. And talk us through, obviously that is the time when the images are being sent to you as the radiologist. Talk us through what happens next if there is something you see that you go, this is not good, because there is such relief when the radiographer comes out and says, everything's fine, you can get dressed. That relief that washes over you is so I can't begin to imagine when you have to go and tell someone.
Yeah.
There's something, sorry.
It's
something
never easy. Definitely.
Talk us through that.
Definitely not easy. So we obviously have a whole chain of a lot of people involved to be able to get a diagnosis at the end of the day, So, and I always tell the people at the front desk, they are the voice and the face of the practice. And we are so blessed to have such a lot of amazing people working for Bay Radiology. So basically from when you make the call to have your appointment done, the bookings personnel or the receptionist, when you come for your whatever you're having, they should have insight in what needs to be done or your prep for the specific examination, And they should tell the patient, if you come for ultrasound of the abdomen, you should be NPO. If you come for a procedure, there's certain medication that needs to be stopped. You need to maybe have certain blood tests to be done and all of that, just for everything to run smoothly on the day that you come. So literally each and everyone's link in this chain of events is so important. And then obviously the radiographer is the one who's going to come fetch you in the front and take you for your examination and do the examination. So she's the one who's going to check whether you're the right patient, whether this is the right examination that we're doing. She'll tell you what to expect of it, whether you need to be, sometimes you need to do breathing, you get breathing instructions for certain scans. Sometimes it's just holding still as best as possible and grinding on your teeth sometimes when your mammogram gets done and the pressure is a little bit more than you expect, But the radiographer then does that part of it. And then when they're done with the imaging, most of the time you won't even see the radiologist, and especially if everything is okay. You never see me. But sometimes when someone struggles maybe to put on a drip or they want to try to figure something out, and they might come ask me to come help them to have a look at the ultrasound or to have a look at this or that. And at the end of the day, like you said, I'm the one who literally tells you, okay, you can go. But then the images should come to me. I'm going to have a look at these images and I'm going to compare, especially with mammography. It is so important to do your mammogram where you've had it the previous time, because we're going to pick up your previous examination, we're going to compare it with your recent examination, and we're going to look for subtle changes from your previous examination. And it's those subtle changes that make such a huge difference in early detection. Subtle changes, subtle calcifications, subtle architectural distortion, stuff that we really need to look out for and be mindful of, before we can tell you, okay, it's okay, you can go now, or I will maybe go.
What happens, Sharon? Sorry to interrupt, but you, the last scan has been mammogram, has been fine, but this one, no, there's something. What happens next?
So what happens next? If it's a clear-cut cancer, then I won't necessarily go check or tell you, because mostly we send the report to your doctor, and I'll give your doctor a call and I'll ask him to look out for this report because something was the matter. All right? And then, because you don't know me on a personal basis, you almost never see me.
So you've not so you see something sinister, the patient is sitting in the waiting room, still in that gown. Then what happens? Does somebody come and say, unfortunately?
Usually not.
Usually not.
Usually not. When you will see me is when we're not so sure.
Okay.
Whether this might be or might not be, and I personally want to have a better look at it. So then I will ask them, for instance, to put you back on the ultrasound bed, and then I will come and have a look at the ultrasound, to see, because sometimes, especially with follow-up mammography, when patients had previous surgery and you can get scarring from previous surgery, it's very difficult sometimes to say whether these changes are due to the previous surgery or whether there's something sinister underlying again, So a lot of the times you won't see me, but when you see me, it's usually because I am coming to do a little bit of more investigation to decide whether what I'm going to put in my report, I'm happy with what I'm seeing.
It must be quite difficult when you see something it must be,
And I keep on telling everyone, I get crazy so easily because it's bothersome, and because what you're going to say on that report is going to be life-altering,
Yes.
Yeah, so it's serious business. It is.
Male breast cancer, how common is that?
We don't see it very often, but we do see it.
You do see it.
We do see it,
right. A PET scan, MRI scan, a CT scan, should every woman be scanned for osteoporosis? What are the different scans for?
Okay. So, like I said, when we screen, we always start at the bottom end imaging modalities, like X-rays, And then from there, if there's something the matter, then we will move up to the next level, like an ultrasound or a CT scan or MRI scan or a PET scan. So a PET scan is what we call, it is a positron emitting radionuclide scan, where they inject a radionuclide, which is FDG, and then we can do functional imaging. So depending on the metabolic rate of certain organs or certain cells, we can do functional imaging. And, if there's something the matter or out of the ordinary, then it presents as hot spots on your PET scan.
Okay.
And then, but this is, at this stage, the golden standard imaging for cancer imaging or for follow-up imaging, because they can detect activity so much earlier than normal scans. And that is also your most expensive scan. And that is the most high-ranked scan as well. So we don't use this for normal kind of screening.
So diagnosis and staging, treatment and monitoring. That is, explain those terms. Once there's been a diagnosis, you continue to be a part of the patient's treatment plan.
Yeah, we do. So your diagnosis is literally the name of your disease. All right? So like I said earlier, if we're not sure what we're seeing, we'll give you a differential diagnosis of what it can be. And then with biopsy, the pathologist will make a specific diagnosis. So, okay, you've got breast cancer. And then that is your diagnosis. And then for staging, we do a scan, and usually with the onco patients, we do either from a base of skull to pubic symphysis, literally from here all the way through your abdomen, to see how far this thing went. Because remember, depending on the stage that we get it. So we get stages from stage 1 to stage 4, where stage 1 is minuscule or in the early stages, and stage 4 is already spread of primary disease. So for instance, you can have primary breast cancer that can spread to the bones or to the lungs or to the liver or to the brain, you know.
And that's why early detection is key.
That is why early detection is so needed here. So that is your staging then. We're going to do a scan and we're going to tell the oncologist that we don't see anything elsewhere, any other lesions like liver lesions. So then you're going to be staged, and then that staging depends on what treatment you're going to get and your most likely prognostic outcome is going to be. And then after that, you're going to be treated and you're going to be closely follow up. So the closely follow up is the next step then after your treatment, to see whether your treatment is working, whether there's anything new coming up, whether there wasn't maybe previously metastasis, but whether it has spread somewhere. So that close follow-up is so very important as well.
So you are a vital part of the medical team for a cancer patient, working closely with the oncologist.
Yeah.
Okay,
yeah,
right.
yeah. And sometimes we do have like multidisciplinary meetings. Like with breast cancer, people with breast cancer, we every second week have a meeting in the morning where the radiologist is there to present the imaging, the pathologist is there to present the pathological findings of the biopsy, the surgeon is there to say what they can do, and then the oncologist obviously as well. And then we literally sit together and they will discuss the best way to go forward with this thing.
It's huge for a cancer patient, isn't it? I mean, when you get that diagnosis, what then happens, you know? Sharon, you are one of the few in your field as a company to have a nuclear physician on board. You kind of hear that and you go, you know, can you briefly explain what...
Yeah, we actually have two studied nuclear physicians, but only one of them is what did I want to say? Only one of them is registered as a nuclear physician because you can't be dual registered. But we do have a colleague who studied as a nuclear physician, and he did radiology as well, and he's actually a quite close friend of mine. But yeah, we do have this these special people in our lives that help us. They are medical doctors who specialized in the use of radioactive substances for molecular imaging, like the PET scan we talked about earlier. So they do more functional kind of imaging. And except for the PET scans, there's other scans that they also do. They do bone scans to look for bone metastases, for instance. They do thyroid scans. They do heart scans. So, they do quite a lot. And we have them on board, and we're proud to have them on board. Yeah.
What is a combi diagnosed R90? I mean, it's a state-of-the-art fluoroscopy, and I'm thinking
like
fluoride,
a tongue
fluoro.
twister.
What is this?
It's a medical imaging system, and it's one of the newer ones that we got hold of, I think not even a year ago, it might be a year ago. But it does both high-end digital radiography as well as fluoroscopy and fluoroscopy-guided procedures.
Explain fluoroscopy.
Fluoroscopy is basically screening. Fluoroscopy is when, I don't know whether you know of like a barium swallow, for instance.
Yes. Mm-hmm.
So with a barium swallow, we would give patients contrast medium to swallow, and while they're swallowing that contrast medium, we will take images within the course of the esophagus to see how the esophagus contracts, and so that is fluoroscopy. Okay. All right. So, but high-end fluoroscopy stuff or imaging-guided stuff will then be like the procedures that I told you about that we do earlier, like angiography. We can do digital subtraction with this machine. Like digital subtraction, it's basically an application where we put it on and it takes away the bone. It subtracts the bone so we can see other parts better if the bone is not overlying anymore, And we can do normal radiography with it, like whole spine imaging, for instance, full-length limb views, for instance. We do, we can do quite a lot with that.
Is AI already playing a part?
AI?
Will it? I mean...
AI is here to stay, I think, and AI is a fast developing field that can be definitely of help in radiology. Also because the demand on radiology is getting so much bigger worldwide, and we only have X amount of radiologists available. I think AI is here to stay. AI obviously still need lots of refinements to do regarding regulatory aspects of it, and a whole lot more. But I think it's definitely going to be of great help in the future.
Yeah. Especially in terms of data. When you've got a lot of data you want to try and interpret. Yeah. Myths about radiation, X-rays, everyone's like, no, Is there more radiation when you go through the scanner at the airport?
My goodness. Listen here, radiation is obviously an integral part of everyday life. I mean, sun rays from the sun, from the Earth's core, there's a lot of background radiation every day, which is not dangerous at all, And we as radiologists and radiographers are the gatekeepers of radiation and radiation protection. And especially with pediatric imaging, for instance, we will not allow you to do full body X-rays if we don't think it's necessary on a child, because at the end of the day, we'll have to please explain that the benefit
the benefit
outweigh the risk.
Has to outweigh the risk.
And then, there's a whole lot of myths that goes around that it's harmful, that you're going to glow in the dark, that you're gonna, that it causes nausea, immediate effect, that kind of thing. But, I mean, there is... I think the big thing for us is that what I just said, the benefit needs to outweigh the risk. And we're never going to do anything that is going to harm you. Like you can maybe get, if you have a radiation field, can get like 20 years down the line in that field maybe a secondary cancer. But for now, radiation might be of the utmost importance to get that cancer that you have now under control, I mean, we won't be able to say if we'll even still live in 20 years down the line to maybe get a secondary cancer in a radiation field. But no, we do not take it up lightly, and we will never do anything that's going to harm you.
Sharon, in closing, key takeaways for the layman in terms of radiography?
We've talked a lot about radiography and radiology and the integral part of it in making a diagnosis and the massive responsibility we have towards our patients to be able to make a good diagnosis and to be able to have a good outcome once a diagnosis has been made, or the best outcome once the diagnosis has been made. The one thing that I would love people to realize is the sooner you come, the better it's going to be, because I know sometimes people feel a lump and then they too afraid maybe to check it out.
The ostrich, head in the sand syndrome,
or maybe just think, maybe it's because of that bump that I had the other day. It's still going to go away. But early detection is obviously of the utmost importance. If there's something the matter, we need to check it out. We need to deal with it as soon as we can to have the best outcome possible.
My father was, symptoms, and he just ignored them. And by the time the diagnosis came, it was too late.
That coughing, that chronic cough. If it's taking too long to resolve, let's do that X-ray. X-ray it's not a lot of radiation, it doesn't take long, it doesn't cost a lot of money. Let's just do it and see what's happening,
And particularly if you have a history, it's very important, isn't it, Sharon, to know your family's history in terms of cancer. It's so important. For me, it's an annual. I go for my mammogram, and I now I have to go for a colonoscopy every 3 years because of my dad.
No. So early detection is of the utmost importance.
And as a resource, I'm going to ask you to recommend your own website because it is really comprehensive. So we can find everything we need to know of this. Is there anything we haven't covered that you think is essential for?
I don't know. The one thing that I have to tell people is that cancer doesn't discriminate. It doesn't matter how old you are, how young you are, it doesn't matter what race you are, it doesn't matter what your socioeconomics are. We see it in all walks of life.
Would you say, Sharon, that it's for me, I don't know if it's an age thing, but there just seem to be so many more people being diagnosed, and not even in my age group. I'm talking about 30s. I know of someone now in her 30s that has had cancer of the nose and has, a little lump there, and
very prevalent these days. It's just as if it's taking over. I know. We feel like that all the time because there's not a day that goes by that we don't do an oncoscan.
Gosh.
And we do a lot of oncoscans in a row every day as well, you know. And that is why we came up with this out-of-hospital imaging facility as well, Mangold Imaging Center, that is literally in the building of where the oncologists are, you know, so that it's a kind of like a one-stop shop for everyone. You can come there for your x-ray, for your ultrasound, for your mammogram, before you go for your chemotherapy maybe, or before you go see your oncologist for the annual follow-up. And it's just a way of trying to get out of hospital a more friendlier environment to go to. So that was one of the brainwaves of us having that Mangold Imaging Center.
It's a lot for you to take home with you, I would imagine, when you've had a rough day, when you know it must be a lot.
Yeah.
But can you share before we close?
Yeah.
What about those times when, wow, you do hear stories of there was a tumor, but it's when you have a success story, it must be so rewarding.
Oh, it is. And how? It truly is. You know what? All the biopsies that we, for instance, do, the pathologist will CC you with the pathology results. And every now and again, when you get a result that you thought is gonna be cancer, and you get the result and it's something completely benign, then you're like, oh, you made my day now, kind of thing, you know. And then we do see a lot of the follow-up imaging that we do, a lot of good results. And especially those who were detected earlier,
Yes,
you know.
lots of those stories.
Lots of those. So we see patients coming for their annual checkup.
Wonderful.
For years and years to come.
Yeah.
So,
My cousin, in actual fact, she 9-10 years ago was diagnosed with breast cancer. She had a mastectomy of one breast, and she's been in remission for 9 years now. It's wonderful.
No, we see that.
Yeah, early detection, found a little lump, and
yeah, definitely.
So wonderful. Thank you so much, Sharon, for this invaluable discussion. Bay Radiology, the website, if anyone wants to go and get some more information, it is bayradiology.co.za.
Yes.
Sharon, thank you for your compassion, because it's clear that you are, even though we never see you and we don't want to see you, stay at the back and just pass the message along that everything's fine. Thank you for taking the time out.
It's a pleasure.
So appreciate it. Thank you.
Thank you for having me, Carol-Ann.